This is a nutrition webinar on the dietetic management of the child with anorexia nervosa, from theory into practice. My name is Sarah Fuller. I'm a registered eating disorders dietitian and clinical lead for my local CAM service in Northamptonshire. And I'm also a research dietitian at Imperial College and a PhD candidate at the University of Northampton. Today I have to introduce my conflict of interest briefly, and I have had some speaker fees and some research grants that you need to be aware of. Today we will be covering a range of topics around how you as a paediatric dietitian can support children and young people with eating disorders in the paediatric ward environment. And then we will have a question and answer session towards the end. So the idea of food relationships is that we all have a relationship with food. There is a range of normal eating, and that can tip into disordered eating. And then eating disorders are a very clearly defined diagnostic criteria with specific symptoms that people may experience. And it's really important to acknowledge that people throughout their lifetime will move through this food relationship from normal eating to disordered eating. We saw a lot of that during lockdowns, where people had a much higher focus on their eating and food than that they would normally have in their normal day-to-day lives. And then as lockdown shifted, we all kind of moved back into less focused on the food that we were ordering and the food that we were eating. And actually people with eating disorders can move from diagnosable conditions into a disordered eating picture, and then back again, but into a slightly different eating disorder. And so it's really important to understand that this is a eating and food relationships are a range, and we can all be within different aspects of that range. And what we define as normal eating is determined by your relationship with the food and your body, not necessarily the foods that are eaten. So what are eating disorders? Eating disorders are serious psychiatric conditions that affect people of all ages and genders. So it's not just children and young people. They can be conceptualized as a way of coping with difficult thoughts or feelings or event that someone's experienced. And they can present in a number of different ways. And this will look very different from one person to another, even within one diagnosis. So let's say anorexia nervosa, which we are going to be focusing on, no three people with anorexia nervosa are going to be presenting with the same restrictions to the same level or the same disordered ways of coping. But in paediatric wards, we know that you're much more likely to be treating restrictive eating disorders, but you may see other young people within that range that we were just talking about, so the eating disorders, but also disordered eating behaviours. And you may see them in outpatients, so weight management services, diabetes clinics, or allergy gastro clinics, or cystic fibrosis clinic. So it's really important as a paediatric dietitian to have a good understanding of some basic principles around what eating disorders are. So there are a number of eating disorders, and as the diagnostic criteria develop, there are more over the years. So 20 years ago, we would have had a much smaller number of eating disorders. So it's really important to understand that new diagnoses do appear within the diagnostic criteria. So the DSM-5, the Diagnostic and Statistics Manual version 5, is one of the manuals that is widely used, or the other manual is the ICD-11, and these are all updated in different years, so you have slight overlap between the different diagnoses. So anorexia nervosa is typically when someone tries to keep their weight as low as possible by not eating food or exercising too much, or both. But we also do see atypical presentations where someone may be of a higher weight and starts developing anorexia-like symptoms, but actually are currently a normal weight, but they may have lost 30% of their body weight. So that might be classed as an atypical anorexia. There's also bulimia, when someone would lose control and eat a lot of food in a very short amount of time, which we call a binge. And binging is a word that we use from day to day now. We binge watch Netflix, and it reflects more of it happens a lot, whereas an actual binge, it can be thousands of calories, tens of thousands of calories. And it's really important to note that someone who has a perfectionist tendency will report the same level of distress for a much smaller calorific binge. So they may have had 500 calories, but report the same level of distress as someone who's eaten 5,000 calories. And so regardless, so it's really important to understand the nuance on each individual. And with people with bulimia, they can make themselves deliberately sick or use laxatives or restrict what you eat, or use exercise to try and prevent weight gain. And we are most likely going to be seeing the use of GLP-1s and Ozempic and Mounjaro, things like that, as a way of potentially purging as well. So you can see how diagnostic criteria develop and change over time. Binge eating disorder would be when someone regularly loses control of their eating with large portions of food until they feel uncomfortably full, and then often feel kind of very obsessed and guilty. So they have the same level of distress, but it's important to note they're not necessarily trying to offset it. Whereas OSFED isn't the school exam board, it is other specified feeding or eating disorders. And that is when your symptoms don't exactly match those of the three main eating disorders listed above. And so someone, if a diagnostic criteria says you must have experienced symptoms for 3 months and actually you've only experienced them for 2, you would probably be diagnosed with OSFED, but in another 2 months' time, you may then get a diagnosis of anorexia. And so you can see how it's really important to note that diagnosis can change through time. Then ARFID, something that we're all becoming more and more aware of, and that is often driven by sensory difficulties, but not necessarily the weight and shape concerns. And there's a strong overlap with neurodiversity, but ARFID can also be linked with the fear of the consequence of eating. So not necessarily eating too much, but actually becoming ill or choking, or fear of contamination from food. Rumination disorder is something that is very rare even within the paediatric environment, but it is seen occasionally. And it's that habitual regurgitation, sometimes of partially digested food, and it's not driven by weight or shape concerns. And then last of all, we see pica, so the craving and consumption of non-nutritive foods, so paper, paint, plastic, wood, those sorts of things. And it's really important to note that it is in line with development. So if someone is at the developmental stage where they are mouthing things and putting items in their mouth as a normal part of their development, versus a pica where someone is actively eating and chewing and trying to ingest the food. So this webinar is going to focus specifically on anorexia, and the most common diagnostic criteria we use is the DSM-5, and that is the relation of the restriction of energy intake relative to requirements, leading to that significant low body weight in the context of age, sex, development and physical health. So again, if someone was overweight but coming down, then actually that's why they may get an atypical or an OSFED diagnosis. And it is the intense fear of gaining weight or becoming fat. And it's important to note that all of us would have a concern about suddenly gaining a large amount of weight. So this fear of gaining weight can be normalised, especially in our society where unfortunately we live in a very fat-phobic environment. So it's really important to understand the nuance of when a teenager says, I don't want to be fat. What does that actually look like? Is that fear of fatness keeping them awake at night? Is that something that they can't focus on their schoolwork because they're worried about the food in their next meal, or how many calories they've eaten, or what might be for dinner? And so it's, again, linking it back to that spectrum. Some of the things that we talk about are very normalised in our society today, but actually to get that diagnostic criteria, I will chat to young people and they will say, the only thing I can think about as in school is what I've eaten for breakfast and what's in my packed lunch. And they sit through lessons and they can't focus on the actual thing because it's 100% of their time. Young people might even have dreams about food. And so it's that disturbance in the way that they are experiencing their weight and shape. So they may have lost an awful lot of weight, but still report that they're fat and overweight. And so it's that disturbance in their body shape that's really important. And also the lack of recognition of someone saying, your pulse is 30 and you're on a paediatric ward, this is really serious. And they're saying, well, I haven't passed out, it's absolutely fine. Whereas most people admitted to a paediatric ward would say, I'm probably quite poorly. And there are restricting and binge purge subtypes. And again, it's really important to notice that 3-month diagnostic criteria. And so that's why some people's diagnosis will change depending on how long they have or haven't had a behaviour. And so it's really difficult to diagnose some eating disorders because there's lots of overlapping symptoms within each eating disorder. There are body image concerns in some, but not in ARFID. The cognitive functioning of young people with anorexia nervosa is very, very specific and unique to that diagnosis. They're often very highly intelligent, lots of black and white thinking and perfectionism. But you also get people to the rare extent at a lower cognitive functioning. Purging can be seen in a number of different ways. So it's really important for us as dietitians not just to say, that person who's really underweight on the ward and is struggling to eat, that's someone with anorexia, because they could have ARFID, they could have OSFED, they could have a number of different diagnoses. And so it's really important to really help the paediatric team to say and understand that we have to be open to a diagnosis and that full assessment by an eating disorders team is really needed. But being on the paediatric ward, you may also see lots of people who present at 70% weight for height who are very medically compromised and have been admitted under a kind of framework from Mead that has red flags and weight loss and a very anorexia-focused formulation. But someone may have OCD or psychosis or really low mood or pervasive arousal withdrawal syndrome, pause, or a trauma. And so some of these other reasons are also mental health reasons, but they're not necessarily driven by weight and shape concerns. And that's where that kind of interview that an eating disorders team would do would help unpick if this is a low mood where someone's just not able to function, not able to get meals and drinks themselves enough and they've lost weight. But there could also be an organic cause. A number of young people have gone on to have diagnosis of, unfortunately, several cancers and things like that, or thyroid problems. So just because they're presenting at 70% and struggling with eating, that could be for a number of different reasons. And the paediatrician's job is always to make sure that we've ruled out the organic causes. So this is the question that I get asked an awful lot, especially by family members and friends. So what's the cause of the eating disorders? And lots of myths might be, oh, it's to do with the parents or this or that. And actually, we don't know exactly what causes eating disorders. We know what makes you more likely to have an eating disorder. So if you're female, but we know that 1 in 10 of people with anorexia are male. And we know that if you've got a binge eating diagnosis, that's more of a 50-50 presentation. We know that if you're an adolescent, you're much more likely, that's the peak onset for things like anorexia, but you could also get anorexia for the first time in your 80s when you've lost your life partner. If you're going through a period of transition, and we see this a lot in school-age children, so that transition from one year to the next, changing teachers, changing school buildings, changing environment, but it could also be moving house or job or pregnancy. Family history is also really important. We know that there is some hereditary traits around eating disorders, OCD, depression, addiction, things like that. And there's a really interesting study at King's College London called EDGY, and we know that certain eating disorders, so anorexia nervosa has around an 65% genetic heritability, whereas binge eating disorder has perhaps a 40%. So we know that different eating disorders have different drivers, and genetics is just one of those key things, because there are lots of people with those genes that actually may not go on to develop an eating disorder, and there are a lot of protective factors for them. If someone's anxious or have low self-esteem, or maybe an obsessive personality or perfectionist traits, then we know someone might be more likely to have an eating disorder. Likewise, if you've ever been criticised or bullied for your eating habits or your body shape or weight, and we see a lot of young people come through to eating disorder services who've been targeted as being overweight in the NCMP National Child Measurement Programme screening, and been identified as overweight, and the family have tried to address this with healthy eating and improved exercise. And what started off with good intentions for someone who's overweight has quickly slipped into anorexia nervosa or an atypical anorexia. If you're someone who's concerned with being slim, things like, we work a lot with ballet dancers, jockeys, models, athletes, rowers, where people get weighed to be in certain areas of the boats. And we know that at elite level athletes, around 20% of them and 8% of males may screen positive for eating difficulties. Those who are in the LGBTQ plus or transgender groups of society, there's a much higher increased risk of bullying. They also have very unique weight and shape concerns for the transgender young people. It's much more about being in the wrong body, not necessarily a specific weight, but they will screen positive around the kind of body image concerns. We know that lots of people with physical health diagnoses, so PCOS, diabetes, inflammatory bowel disease, celiac disease, will all screen a lot higher for because there's a higher focus on food and physical health already through the medicalised monitoring. And we also know that those with a history of abuse or trauma, and also things like isolation. And we saw in COVID a significant rise in children and young people being admitted for eating disorders. But one thing I really want to press home is this is apparently a simplified model of what might cause eating disorders. So kind of I've gone through quite a few extra additional points, but this is apparently is a simplified model. And what it says here is it is not the parent's fault. And this is very much a myth that I wanted to bust today, because lots of professionals will say, put the blame at the parent's door. And actually we know that eating disorders treatment is twice as successful when a family-based treatment model is adopted, and that parents are key to that. And so your parents are your superpower. They are the ones who know their child best, and they are the one who are going to get them to eat. And so eating's really difficult when we focus on anorexia, and on a very busy ward, someone could be easily missed who's really struggling with their eating. And so there are lots of intrusive thoughts around weight gain and shape concerns, and the anorexia can have a narrative voice in the young person's head where they're saying, she's too strong, or she's telling me I can't, or, you know, it's often given a name. So some people might name it as Voldemort or Anna or anorexia. And so all these really difficult, intrusive thoughts can be 24/7. And that can lead to difficult emotions around fear, guilt, shame, and young people will often report that they feel fat, and feeling fat is not a feeling. When we think of feelings, they're happy, sad, frustrated, cheeky, jolly, all of these different emotions, but fat is not one of them. And then in the starved state, when you've got gastric emptying that's been reduced and reduced peristalsis, you often get bloating, discomfort, and constipation. So it becomes this self-fulfilling loop where young people are really struggling from psychological reasons, but they're also getting those physiological reasons as well. So as a dietitian, what is my assessment? So linking through my ABCD framework, so the anthropometry that I'm looking for is, of course, that weight and height. And often we will have a weight, but without a height. And we have to be quite mindful of kind of manipulations of weight, so water loading or inserting weights or wearing extra clothes and things like that. I am looking at the rate of weight loss. And so we know that in the MEAD, the Medical Emergencies and Eating Disorders framework, with the red flags, 1 kilo a week over a period of 2 weeks is going to be that red flag. And actually what we might see is that parents might report, well, she used to have a size 12 skirt for school and now the size 6 is held together with a pin. And so you can get quantification of that rate of weight loss in a different way. But also we can calculate the percentage median BMI, and less than 70% would be that red flag. And there's a link later on in this in the slides here to a calculator that will do a full MEAD assessment, and you can get the percentage median BMI through that as well. With biochemistry, I'll be looking at the refeeding blood, so Usinase, liver function, calcium, magnesium, phosphate, and of course correcting anything prior to feeding, or if it drops, to not increase feeding until it's corrected. We often will see hyperglycemia, but in these young people who are awake, orientated, telling us to go away. And so it's quite a difficult line to walk with hyperglycemia around, are they symptomatic or are they managing this okay? It is unlikely to be a complete lack of glycogen and sugar that perhaps some adult patients may pass away from, because in children and young people we tend to act a lot earlier. And we know that monitoring a low white cell count is at increased risk of refeeding. From that clinical assessment, so we're looking for weight loss, we're looking for sunken scapula, cold peripheries, a handshake is often a very good diagnostic test. Looking for lengo hair, so that fine fuzzy peach hair that might be in various patches or on their face or chest or back. Someone may have pressure sores and also have very slow, delayed speech. But an atypical presentation may present with slightly less clinical signs. Getting the dietary history, there's often a picture of increasing restrictions. So started off with healthy eating, then perhaps cut out puddings, then perhaps went vegetarian, then perhaps added in gluten-free. And the kind of restriction often has this growing pattern versus someone who's maybe in food refusal, who was eating McDonald's at the weekend and then since Monday hasn't eaten. There might be strong sensory preferences for someone around, is it dry food, is it crunchy food, is it soft food, are there certain foods that they've never been able to manage? And I'll be looking at the kind of eating behaviours that we might see that would need support. So if someone's excessively cutting food or crumbing, so breaking it off so that there's more crumbs spilling everywhere, hiding foods in pockets or hoodies, or dropping food, or perhaps smearing it on the plate and hiding it under the knife and fork and things. And I said earlier that there was going to be a link. So the MEAD dashboard is a really good link, and it comes up with your red, amber, green, and you can just click through and it will include the percentage median BMI calculator. So as a dietitian, that would be the summary of my dietetic assessment. So the treatment of malnutrition is nutrition. And so this is where dietitians, this is our thing. So we would often focus on 3 meals, 3 snacks. And I've put in brackets 3 nourishing drinks, because actually lots of our young people will say, eating's really hard, but drinking's okay. And so it's really helpful to perhaps add in some nourishing drinks and then perhaps transition to a solid snack at a later date. So just to have that in your back pocket as an alternative of what you can be offering. And I would always do a meal plan that has one version for the patient, which basically says you have 2 Weetabix with all your cornflakes or this or this, and this much milk or whatever, but not with the calories, because they will then focus on that, and then they will try and, because they're so anxious, try and change the plan. It's very helpful because paediatric wards are very busy ward environments. To agree kind of set meal times. So actually, your breakfast is at 7:30, and a parent will be on the ward to manage that. So it doesn't matter that there's handover at the same time, and we expect that meal to be done by 8:00. If not, we'll then offer a supplement. And so the copy of the meal plan that the nurses will have will say how much have they managed to eat, and therefore how much supplement do we need to offer. I do use the paediatric compact formulas in both nutrition support and enteral nutrition support, because actually we often have children as young as 8 coming in with potential eating disorders, but also their weight can also be under that kind of threshold. So for me, for making practice as safe as possible, I've always been using the paediatric ranges, but that's just a personal preference. And we know that MEAD guidelines, so the medical emergencies in eating disorders, they suggest refeeding in a very different way from the NICE refeeding guidelines. So that says starting at 1,400 on day 1 and going up every day by 200 calories until 2,400. Now, there's obviously going to be a little bit of nuance with that. If someone is come in not managing anything for several days, 57 calories having a lolly once a day, and suddenly day 1 they manage 890, that's absolutely brilliant. We might need to do day 1 again and try and get them up to that 1,200. We're not going to be, unless they are severely medically compromised with really high Pew scores on a high dependency ward, things like that. We're not going to be kind of rushing in with tubes at that stage. And the idea of meal planning on the paediatric ward, it is that foundation of enough. We're establishing that regular eating of 3 meals and 3 snacks and getting physically safe and promotion of physical health restoration. So ideally, we want them discharged on that 2,400 and starting to gain weight. Then the eating disorders team can take over and do the slightly scarier foods like, chocolate puddings and snacks and meals out and things like that. So it's not necessarily the role of the paediatric ward to be getting someone in a place where they can have burger and chips, and things like that. But if you are able to do that, then that's absolutely brilliant, because many young people do respond so well to the paediatric ward environment and can do some of those food challenges, but they're not essential to that admission. I would want someone eating 3 meals, 3 snacks, 2,400 calories, and then I'll be more than happy to take back that person's care. So one of the things that we're becoming more and more aware of is the role that food sensory adaptations have in restricted eating. And we also see, like we do with ARFID, we also see a strong overlap with anorexia nervosa and neurodiversity. And so a reasonable adjustment for neurodiversity is a legal requirement. So sensory adaptations to help someone eat with anorexia nervosa is that legal requirement for the neurodiversity, but also if they are detained, then it would count as that least restrictive practice. And there's a really good link here from the CNTW Trust around supporting regarding ARFID, but it can also be adapted for anorexia. And so these are some of the questions. It's as simple as, I want to eat off my own plate. Can we bring my favourite bowl in? I don't like my breakfast cereal wet, but I will drink milk, but I will have them separated. And so these are some of the sensory adaptations that might help someone get from that 800 calories a day. They might be saying, I didn't eat that because my breakfast was too soggy. Well, we'll separate them out. Will that make it better? And then the next day they manage to complete fully. So these are sensory adaptations for anorexia that can be really helpful on a paediatric ward. And likewise, these are a few more kind of questions, and I've taken these directly from the document, but they can be dragged and dropped into a ward care plan really easily. And you know that you've got that least restrictive practice, you've got the kind of, these are all reasonable things. It's not saying I need to be in a certain specific environment within the ward. It's around what is a reasonable adjustment for the ward to be able to make to support someone to eat who's struggling. Weight monitoring. It's something that I get asked an awful lot, and if there is a medical reason, so if we're really worried about edema or that someone might be on HDU, you may have a separate weight monitoring policy, and obviously go by that if there's a clinical indication. But usually we would recommend no more than twice a week, and that same time of day, ideally before eating and drinking, and ideally after passing urine. One layer of clothes is ideal, and perhaps in the ward it could be in a ward gown or a nightie or something that you can just make sure that there's no kind of falsifications. And a lot of young people find it containing to when we have that conversation of, do you want to know the number? And the answer often is no, because it's not going to be right. And so they will be really distressed that the number is maybe going up. And especially during refeeding. So we often say you can step on backwards. This is a clinical measurement that your meal plan is not going to change off the back of it. We still need to safely refeed you, starting at that 1400, getting back to that 2400. But there may be that initial jump in weight during refeeding. And so that kind of education from the dietitian can be really important. So if someone's been in a starved state, has been reducing their eating, has really reduced glycogen stores, but also is very dehydrated, and then on a mission has had a couple of litres of IV fluid and start on a 1400 calorie meal plan, and suddenly having carbohydrates. So you can see really large shift. The largest I've seen is about 5 kilos in those few early days. And that led to a lot of distress with that young person. But when we're able to break it down and say, actually, you were only drinking 1 Diet Coke a day and you were being sick on that. What that meant was we've increased your fluids from that 330 mils to 2 litres every day. So there's some weight straight away. You're now on this meal plan and your glycogen stores. So with every 1 gram of glycogen, you've got 1 gram of water. So you're actually restoring your glycogen stores and your hydration, your water stores. And it isn't necessarily what her eating disorder thought was that actually this is true weight gain here. And we were able to explain and contain the anxiety. So NG feeding, it can be really, really helpful for some people who say, I just can't do it, it's too hard. So whatever oral intake they've got, they may have tried really hard. And it's around having a conversation around a supportive short-term intervention. Okay, you're finding it really hard. Why don't we try for a couple of days of having this feeding tube? And with some young people, it helps them restart eating. It breaks that starved state. It gets the right amount of nutrition in, and you can reestablish that regular eating. But also, by having that tube, it also takes them further away from that end goal of eating 3 meals, 3 snacks and being able to go home. So it's not something that we want to rush into. And we know that NG feeding and tubes can be a real badge of honour for someone with an eating disorder. They can be, look, I'm sick enough. And once we've passed the tube, it can be really challenging to remove the tube and get someone to re-establish eating. And so that can be quite a challenging conversation. And so it's really important to not use NG tubes as a threat, but saying, I can see how hard eating is for you, and that's really common for someone in this situation. Why don't we try and see if it helps? If not, we can stop it. Because what you don't want to do is end up in a situation where a tube's there and it's actually unhelpful for someone. However, we sometimes need to feed young people under restraint if they are so physically compromised that we fear their life is at risk, or that we fear that that is where we're going to end up in a few days. And so it's this really difficult balance that we're trying to manage, of saving someone's life, but also acknowledging that this is a really traumatic thing that we're doing. And everyone has to be detained under a legal framework. So you can do one feed without a legal framework whilst waiting for an AMP or a court order or anything like that. But after that, then you must legally have and it'll be different in different countries. England and Wales have the same legal framework, but Northern Ireland and Scotland, you'll have your own legal frameworks that are slightly different. And actually, we've written guidance on how we've modified dietetic practice. So you wouldn't feed someone 6 times a day, so replacing those 3 meals, 3 snacks, but you would go to 2 feeds, and you can use a syringe bolus rather than an enteral pump, and we can start at much larger volumes, and things like using a wider French tube and those compact feeds would reduce the volume in order to be able to facilitate the feed in the safest but quickest way. And one of the things that I often try and support paediatric colleagues is they all say, I'm not trained to talk to these patients. I have had no therapy training, and I feel really unskilled because I make them cry when I go to see them. And as the dietitian, that's a really difficult role to own, because the reality is they're scared of food, and we're talking about food. And food and re-establishing regular eating is the thing that they need to do in order to get in a medically safer place. And so I often try and focus on that calm, confident, consistent coaching and collaborative communications. So, not necessarily getting tied down into specific conversations that seem unhelpful, because we could spend all day talking about calories and not end up ever eating. And so reflecting that the behaviour is driven by fear. So someone might be crying, say, I know that this being on a meal plan is really scary. Being on the paediatric ward looks really scary for you. I can see that you're crying, that real validation, but you are very poorly at the moment, and this is what we need to do. We can get very bogged down into logic that would perhaps work with other illnesses, but not necessarily anorexia. No amounts of beeps and buzzers will be scary enough for someone to go, oh, that's all right, I'll just sit down and eat, thank you very much. So those clear and firm boundaries are often what young people tell us that is really helpful. And so I've written some kind of phrases down here that's that are often quite helpful and containing for dietitians to be using. So with those difficult conversation, and just say, I can see this is really hard for you, and I can see that you're struggling. You're noticing and validating that struggle and that distress in them, and say that you're there to support them, but not their eating disorder. And things like and rather than but. So I can see that this is really hard for you, and we still need to do it. Because if you put but, it makes as if there's maybe a choice. Maybe I don't need to do it. Help them zoom out. Help them say, if you want to get back to horse riding, this is Project Horse Riding. That family trip to Paris that you're working towards, this is Project Paris. So kind of using more positive reflections and positive goals, rather than, if you do not do this, we will pass the tube. So I wanted to end towards the webinar with a case study of hopefully a young person who's relatively familiar to most of you. So she's 14, she's been admitted to the ward from the eating disorders team, and she's been diagnosed with anorexia, having lost 14 kilos in 4 months. So she was started with family-based treatment, and the local CAMS team have been able to provide 2 meal supports a day. However, she's continued to lose weight, and she's kind of tipped into a number of red flags on the Mead risk assessment. So she's admitted to the ward for refeeding. But this is on a Friday afternoon. This is when most patients get admitted. And the ward staff start an out of an hours generic refeeding plan, because I always think if you've got a blank refeeding plan that's day 1 through 6 that is there for out of hours admissions, the nursing staff then know where to start. Okay, it's 8 o'clock, you still need a night snack. This is what we're doing. And so if anyone's on leave or it's a long weekend, then all of these kind of scenarios are useful in order using ward catering and things like that. So you go up and review her for the following week, and you're asked around kind of thinking around a more bespoke meal plan. So she's managed to do the first few days of refeeding, but has needed some supplements because perhaps you've put the wrong type of cereal on, she doesn't like Cheerios or cornflakes and only prefers one brand of cereal. So your dietetic plan could be around making things a little bit more bespoke around managing that, as long as the parents feel that that is an appropriate thing. If they're then saying she's never eaten these foods, that's fine. But if she said 3 weeks ago she was eating that and we're really curious as to why she's no longer doing that, that might be something that you want to consider. And then if we're in a situation where she's still deteriorating on the ward, so she's pusing at 4 consistently due to low blood pressure and heart rate, and the medical team are the paediatricians are getting really worried about her, as we notice that she's doing lots of squats, walking in the bathroom, things like that. There is a bed at an eating disorders unit, but they're saying they can't take until she's medically stable. And a really difficult decision is taken to do NG feed under restraint, because the ward have tried NG feeding. So an example would be having, for day 1 of refeeding, that 1,400 calories can be split into 2 feeds. And again, I use the Fortini compact multifiber, and you can just have some water to thin it down, just to aid passing through with the syringe into a tube. And depending on hydration, you can have a smaller or slightly larger flushes. And actually, in this case, this is a very case similar to a case that I've looked after. After that one feed, she was able to say, I really don't want that feed again, so I'm going to start drinking some of the supplements orally, and then being able to start eating some snacks. And after an intake of around 1,500 calories, the SEDU say, okay, she's no longer scoring on P's, we can finish that refeeding process with us. So my top tips would be those paediatric compact feeds, and think about you adding collagen or a fat-based supplement to further reduce volume. You can also consider things like Maxidor in the flushes before and after to further reduce the volume of the feed prescribed. And an example of the another feed is given below as well. And I wanted to end on a really nice poem from someone who I used to work with, and she was really, really very poorly. And actually, it reflects something that as a paediatric dietitian you may not see, is that full journey where someone's gone from being really, really poorly, really malnourished, needing feeding under restraint in a paediatric ward, to going out, living a best life, up to a lot of mischief, and having an awful amount of fun, but more importantly, being able to eat and drink. And so I wanted to end on that. But I've also got some signposting for you around some additional resources for those who have found today's talk quite interesting, around some additional resources for patients and families, and around meal support, around parent support, around resources for schools, and also resources regarding NG feeding under restraint. So there you go, and I would like to finish now, and hopefully we can have some questions.
Well, thank you so much, Sarah, for taking us through, I think, such an important and really increasingly relevant area, isn't it, for dietitians in clinical practice? And I think for sharing some of your experiences and advice when supporting these types of young people. When you share the case studies and the poem at the end, I think that really does bring the patient experience to life in such a powerful way. So thank you so much for sharing that.
You're very welcome.
So we now have about 15 minutes for questions and answers, but just before I launch into those, I just wanted to reintroduce myself. To those of you listening that don't know who I am, my name is Megan. I'm a dietitian and the paediatric medical science liaison for Nutricia. And I have the privilege this evening to ask Sarah some of your questions that have been coming through. So thank you very much for sending those over already, and do keep them coming. And we'll aim to get through as many as we can in the next 15 minutes. So without further ado, if you're happy to just launch straight into the first question, Sarah.
Yeah.
So this is actually a question that we were actually discussing before we jumped on to the webinar this evening. And it's very much around sort of the training and the support for dietitians. And I know you shared some brilliant resources at the end of your presentation. So I suspect that's quite a good place to start. But is there any training or support that you would recommend from your experience for dietitians that are new to working with eating disorders in paediatrics?
Yeah, that's a really good question, and one that I think gets asked all the time. So there are some BDA courses around managing mental health and eating disorders, and additionally there is national training for eating disorders for the clinical teams that usually involve paediatrics, and that will hopefully be running next year again. However, there hasn't been any specific training that I've gone on around communication, and that's something that is often asked. Like a lot of my dietetic colleagues say, I'm really worried about talking to this patient group, like, they seem to be crying a lot and things like that. And I think one of the things that I've learned through making many mistakes is that going into any patient contact, if you're feeling slightly uneasy because it is someone with an eating disorder, and this isn't a clinically strong point as perhaps some other conditions might feel for you, like coming in saying, I am the paediatric dietitian, I have a really clear job here. This is going to be a difficult relationship for us to manage because you're here because the food's really scary. And I get that, and I can see how scary it is for you. However, it is my job to try and make it as less scary as possible. So it's really important that we work together. And if I say anything wrong, or if I've done anything that hasn't helped, please let me know. And I think having that open dialogue, because you will get teenagers who will tell you exactly whether you've done something right or wrong. And it's that constant learning and refining of your kind of clinical mannerisms around these patients. And even as someone who's been doing this for nearly 20 years, I can still get it wrong with patients. There's no guaranteed way of communicating with some of our young people without causing distress. But I think it's really important just to say that it's okay to do, to show your vulnerability and say, I'm really sorry if I got something wrong. I'm going to try really hard not to do it again.
Yeah, so encouraging that open and honest conversation.
Yeah.
Thank you.
And there's no specific training for that, unfortunately, but there are the BDA courses and the national eating disorders training.
Brilliant, that's great. It's a good place to start. Another question, more sort of broad, but it talks about, do you talk about calories with your patients?
Interesting one, very topical. Both yes and no. So it depends on the patient. So sometimes it can be helpful. Where's the patient starting? If they have been weighing and measuring food and calorie counting and are obsessively looking at labels, looking things up online, that is their starting point. That is the behaviour that they're doing to try and make themselves feel safe. So whilst I wouldn't encourage that behaviour to, let's say, a 12-year-old who's like, what's a calorie? I would not be mentioning, I would maybe kind of speak to parents beforehand and say, what's your understanding of their understanding of calories and nutrition and blah, blah, blah. What's fueling some of this? What behaviours have you noticed? Whereas if the young person's there already, it can be a way of creating safety. So if they're saying, I calorie count, I'm going to look it up, blah, 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 it's on my app, da, da, da. You go, okay, we can have a conversation about the types of foods within a certain meal or snack, but my job is to set the calorie limits. So a main meal might be 500 calories and a snack might be 200 calories. We can have a discussion about what types of snack. We can have a discussion about what types of meal options would meet that 500 calories. And that's a really good place of starting, of creating a sense of safety, but also being mindful that not everyone calorie counts, and some people are like, what are calories? And what we don't want to do is create a new anxiety and a new element to eating distress that they didn't know about beforehand.
Of course, so taking quite sort of an individualistic approach, patient by patient basis. Yeah. Okay, brilliant. Thank you. Another question, I think this is probably very true and relevant to all therapy areas, is how do we manage acute ED admissions, so eating disorder admissions, in the current NHS climate and situation? So they've referenced things like staff shortages and feed shortages, and I think that's probably something all dietitians in the NHS can appreciate.
Unfortunately, I don't have a magic wand for many situations, and I think we manage these admissions with the same care and compassion that we would do any medical diagnosis. So when I was a paediatric dietitian many moons ago, our cystic fibrosis patients would come in routinely for 2-week IV antibiotic admissions, and they would be on the ward. The bed would be used for 2 weeks, and then they would go home. Then the next one would come in, and it kind of feels a little bit like that with some of the eating disorder patients. When you get rid of one, another one comes in, and because the MEAD guidelines say like the safest way to refeed is that 6-day refeeding, they're in for a minimum of 6 days, and some of them don't kind of sail through and manage quickly in the same way that someone with cystic fibrosis maybe sometimes needed a 3rd week of antibiotics to see the same improvement. So the NHS is short-staffed, is stretched, but we have the same level of compassion regarding, irrelevant of the diagnosis, whether it's a physical health or a mental health condition. And just because it's a mental health condition, there are very serious physical health things wrong with these young people. We often see pulses in the 30s and 40s, and that young person would probably be the sickest patient on that ward. So it's really important to try and maintain that sense of compassion. And, if there are a feed shortage, ring your rep, ring Megan, not all at once, and say, what's the alternative? Can I use a slightly different product? Can I use the adult version for this patient because they're 15 or 16? Have those conversations. And, if you are really stuck, reach out to a colleague who is a bit more specialist in eating disorders, because they may have come up against exactly the same problem, but come up with a creative solution.
That's brilliant. That's a great answer. Thank you, Sarah. Another question has come through around sort of advising to tell the patient about the calories on the meal plan. I think that's probably building on off the back of the question you answered. So I think you probably answered that. But the other part of the question is, or is this meal plan a copy just for the ward staff? So is it more a case of having, I think what they're asking is it okay to have a meal plan with the calories for the ward staff and then just a meal plan without the calories for the patient?
Absolutely. And that's exactly what my practice is. So the ward staff have pro formas, and we have the meal plans laminated, because otherwise they lose them. Laminate something on a paediatric ward, it never gets lost. And so for them, it's really important, because if a lot of nurses, paediatric nurses, will not know how many calories are in a sandwich, will not know how many calories are in a bowl of cereal. They could figure it out, but it would probably, they want a ready reckoner, an easy win. So what we've done is listed the foods, and then with a table next to them, the line of how many calories, and then how many meals of the usual supplement that we would use. So if someone's had half a sandwich, they can go, oh, it's half of 400, so that's 200, therefore it's half of that many meals, therefore I know to go and get that supplement and pour out that much. And it's just made it much easier for the nursing staff, because the one nurse who feels confident in managing that might be on annual leave for 2 weeks, and it might be someone new who's rotated into paediatrics, and so gives that nursing staff the support, so you're not getting bleeped about how many calories are there in a slice of toast and how many meals of supplement do I need. But for the patient who isn't calorie concerned, just having the list of foods of what they need to eat and when is helpful and containing. We don't need to give them a number to focus on.
Absolutely. And I suppose to some extent you're just building on saying that it can help with nursing staff rotating in. That might actually help with kind of the staff shortages, as you're saying. Actually, you're not running up constantly every 5 minutes to kind of clarify. You've already got that information there. Yeah. So that's brilliant. Another question. I know that you mentioned sort of family-based, involving the family is really important. I think you said it was about twice as effective as just sort of individual therapy with that young person. And you also speak about sort of communications using like the 6 C's and those kind of top tips. So in your experience, do you find sort of the most effective ways to involve families in treatment where they might be resistant? Is there any kind of top tips you have where that patient might be resistant to involving the family? Is there anything you've found have worked, or is this very much kind of an MDT approach?
So if in doubt, recruit your friends. Always, because a psychologist will come to this some different solutions to a family therapist, to a nurse, to a dietitian. So what I wouldn't say it is not the job of the dietitian to help a group of parents who are struggling to engage their young people in treatment. It is your role as the dietitian to feedback around the nutrition, the rehabilitation, and the nutritional risks associated with them. But actually having the empathy and saying, look, we get that you don't want any of this. It's very clear you don't want to be here. You'd much rather be at home doing your own thing. But now we're aware of you. We have a duty and an obligation to look after you. And we know that the best way is by doing that is skilling up your parents, because a lot of young people say, I don't trust my parents, blah, blah, blah. Hang on, your parents are being, given a lot of information now about how to manage this going forward. And that's where perhaps doing things like a phased discharge can be really helpful. So rather than saying, right, day 6, dinner, off you go, actually saying, okay, well, why don't we do dinner and go home and, after night snack, go home, have a sleep in your bed. And, because that's going to be a proper sleep as opposed to a ward sleep where there's beeps and buzzers and, everyone gets woken up early. Mm-hmm. And let's see how breakfast goes and come back up to the ward after breakfast. So you've got that trial run of breakfast. And then the next night you can go home for a sleep, breakfast and snack, and just gradually build up that confidence. And so you can have, 3 or 4 extra days where you just ease that transition and can allow the eating disorders team to firefight any teething problems that the parents and the young people may be experiencing around that transition from a very supportive ward environment to home that could be very, very scary.
Yeah, absolutely. That's a great answer. Thank you. Another question, we've had all of them coming in now, so in the last 4 minutes. Really good question, actually. So and I think this probably builds a little bit on some of the things you talk around where you may need to make allowances, perhaps if someone has sort of neurodiversity and those kind of considerations. But this question says, if the young person insists on sort of vegan, milk-free, gluten-free, so other food intolerances that are not necessarily proven, and the options aren't available on the wards, is it appropriate if the parent is willing to provide these products for patients while they're an inpatient? What's your sort of stance on that?
I think the bottom line is compliance with a calorific prescription. So if we're refeeding, Mead says start at 1400, go up by 200 every day, get to 2400. Easy as that. However, there is often this kind of snowballing kind of vegetarian, then vegan, then, like you say, lactose free, blah, 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 all these additional restrictions. I think there would be an element, and different people you can challenge. So some people come into the ward straight away and go, and the nurses go, you're not allowed that, you have to have this. And they go, okay, and off they go. And that's done almost by chance. However, there will be a cohort of patients that say, I'm not having this, blah, blah, blah. What we don't want to do is push them into a corner so much that we go, well, they haven't eaten, they're deteriorating even further, and we're now thinking of feeding under restraint. So it would be the least restrictive thing to say, okay, right, you're saying you will eat, but enough of this, let's give it a go. And actually, a lot of patients, in my experience, will some will just kind of take to it and go, okay, that's given me some control over my eating, but I now know that I need to have it more. And it allows the parents to understand. And your role as a dietitian, go, okay, well, if you're milk free, did you know about like Oatly cream and this and that and blah blah blah? We can actually get the calories in different ways, and so you can use your core dietetic skills to help the parents kind of not serve salad three meals a day, because I think a lot of parents will go, I don't know what's vegan, I don't know how to manage this, and so the core dietetic skills can be really helpful then. And you say, you know what, the eating disorder team can challenge this at a later date. So be very clear in your communication, saying, I am not saying that this is an agreed dietary restriction for the next 10 years. What I'm saying is, at this phase of treatment, we are going to give this a go. If it doesn't work, we can try and address it in a different way. But it might work. And actually what we know, and my personal experience from refeeding a lot of young people, is a couple of weeks later, a couple of kilos later, they come in and go, yeah, you know, this kind of like gluten-free food, it doesn't taste as good. And actually we didn't have any, and so I'm having normal bread now and things like that. And so but that's my experience as an eating disorder dietitian. Being the paediatric dietitian, you're potentially on the kind of firing line a little bit during that acute emission. You don't necessarily see those changes. So my top tips would be to say, this is not an agreed sanction of dietary restriction. It is effectively a truce to see if we can manage this. However, if we come back and we're still on this and it's got worse, then it's a sign that this strategy isn't working.
Yeah, no, that's really clear. Thank you. We're actually 8:30. I'm just wondering if we can fit one more in. We'll try one more, and then we'll pass back to the hubs, because there's some great questions coming in. So this one's kind of around MDT working, which I think is, of course, very important across all therapy areas and anything you're working in. But especially around sort of kind of perhaps high emotional things such as NG feeding under restraint, which I know is kind of your speciality area, isn't it, Sarah? How do you sort of ensure kind of there's a consistency in the approach, and your approach to it as an MDT if you are going down that road of sort of feeding under restraint?
Yeah, I think it obviously it's a really difficult subject, and not one that any of us as dietitians ever thought when we learnt about NG feeding. I can remember as a student learning, doing my first NG regime, being proud as, anything, being like, oh, look at this, I've done this, and isn't it amazing? The idea of feeding anyone under restraint is absolutely horrific for anyone who works in mental health or paediatric, a parent, carer, anyone. And so I think it's really important that we all are able to share our voices within a multidisciplinary team. So that will include the CAMS team, potentially crisis, any in-reach, the psychiatry, the psychology, the family therapists, because everyone will bring slightly different perspectives. Because you as the dietitian might say, but actually they're drinking supplements, they're able to, just because they're not eating, it doesn't mean that we need to do this. You're able to bring a different perspective around how we manage nutrition. I refed someone completely on slices of bread with jam once, and she was so bored after day 4 of eating 18 slices of bread and jam that she asked for something different. And I was able to hold that unique way of, at that stage, was all I can eat is bread and jam. I was like, well, you're going to have to eat lots of bread and jam. And then by day 4 she was like, if I see any more, I was like, is there anything else you'd like to eat? She was like, yes please. And so we're able to move on. So I think the dietetic bit can be really helpful in thinking creatively of alternatives if NG feeding is needed. And NG feeding under restraint, because I think lots of people see it as, a safety net of, oh, we can just pop an NG in and then we don't have to worry about the distress at meals. But actually it takes someone further away from eating and eating independently. So sometimes the distress is appropriate that we see them, and because they're actually kind of starting to work things through, and this is where we can go, I can see that you're not happy with this, how can I make it a little bit easier for you? Is it that we think of snacks as supplement drinks because drinking might feel easier? Is it, how can I work with you to make this just that little bit easier, that 1% easier? and kind of really reach into that and say, I can see that 99% of you doesn't want to be here, and 1% of you is really, really scared. And 1% of you knows that you probably should work with me, but 99% of you says that don't work with a dietitian. So it leaves us in a stuck thing. So let's try working together.
Yeah, that's brilliant. I guess it comes back down to that communication piece, doesn't it? And working with that patient. Absolutely. So thank you so much, Sarah. I think that's probably all we have time for, unfortunately. There's been some great questions this evening. So thank you again for sharing your expertise with us all. As usual, it has been a pleasure speaking with you. And thank you to those of you that have dialed in today. I really hope you found this to be very informative. And hopefully it's given you some confidence to apply some of the learnings to your own practice. We'll now hand back to your local hubs, and we wish you an enjoyable rest of your evenings. Thank you very much.